Hello YouTube, I am Dr. Rabiul. I work as a lecturer of pathology in a medical college hospital and I am making this video for my students. Hope someone finds this helpful. Okay, now today's topic is pernicious anemia. In this video, first we will define pernicious anemia and discuss the pathophysiology of pernicious anemia, which will also include the genetic factors and autoimmune factors. Then we will discuss the common clinical features, lab diagnosis and treatment of pernicious anemia. Okay, so let's begin. First question, what is pernicious anemia? So as written in your textbook, you will see pernicious anemia may be defined as a chronic disorder of middle-aged and old-age people due to autoimmune gastric atrophy of the parietal cell resulting in vitamin B12 deficiency. Okay, now don't get scared. I will repeat the definition and I will explain this definition line by line. Okay, so I am repeating the definition. Pernicious anemia is a chronic disorder of middle-aged and old-age people. Now remember, this line is important because pernicious anemia is unusual before the age of 40 years and it is extremely rare before the age of 30 years. So always keep that in your mind when you are taking the history of the patient. So going back to the definition, pernicious anemia is a chronic disorder of middle-age and old-age people. And what's happening here? Here there is atrophy of the gastric parietal cell. Remember, atrophy means decrease in size. So gastric parietal cell are decreasing in their size. And since gastric parietal cell used to secrete a special molecule known as intrinsic factor, which was required for vitamin B12, so we are having vitamin B12 deficiency as a result. Okay, so pernicious anemia is a chronic disorder of middle-aged and old-age people due to gastric atrophy resulting in vitamin B12 deficiency. Okay, so now that we have cleared the definition of pernicious anemia, now we will discuss how pernicious anemia develops or why pernicious anemia develops. Okay, so regarding the pathophysiology of pernicious anemia, you will see in your textbook that there is mainly two factors responsible for development of pernicious anemia. The first one is genetic factor and the second one is autoimmune factors. Okay, so we will discuss these things one by one. Now, what are the genetic factors that can cause pernicious anemia? Always remember, pernicious anemia has a tendency to occur in the family. There is 10% incidence where pernicious anemia is reported in the family of the patient. In another word, the patient in 10% cases will give history that some other relative in his family has pernicious anemia. Okay, so that's number one. It has some familial predisposition. The second point about genetic factor is regarding blood group of certain individual. It is seen that pernicious anemia is more common in blood group A. Okay, now that doesn't mean that if someone has blood group A, he will or she will have pernicious anemia in his or her middle age. No, it's not like that. The thing is, the percentage or the chance of pernicious anemia is more in persons of blood group A. So that is the second genetic factor. Pernicious anemia is more common in blood group A than other blood group people. The third point about pernicious anemia's genetic factor is regarding certain ancestry. Pernicious anemia is more common in Northern European ancestry than other European or Asian ancestry. Okay, so that is another point about the genetic factor. And the last point I would like to add regarding the genetic factors of pernicious anemia is eye color and skin tone. Pernicious anemia is more common in people with blue eyes and white complexion. Okay, so those were the genetic factors that can be linked with pernicious anemia. So now we will talk about the more important autoimmune factors. Okay, so remember, pernicious anemia, this is an autoimmune disorder. Okay, and what is autoimmunity? Remember, our body has an immune system. It is a very high-tech system that's main function is to give us protection from different types of harmful agents. But the problem is sometimes our immune system starts reacting on our own cells, on our own tissue, and that results in something called autoimmunity. And regarding autoimmunity in pernicious anemia, what are the autoimmune factors of pernicious anemia? The first one is other autoimmune disease. Let me explain. It is seen that pernicious anemia, patient of pernicious anemia often has or often gives history of some other pre-existing autoimmune disease. Say for example, a patient of pernicious anemia can give you history, past history, that he or she had hyperthyroidism, hypothyroidism, Hashimoto thyroiditis, that is an autoimmune disease of the thyroid gland, Hashimoto thyroiditis, etc. So that is the first point about autoimmune factors, that the patient may have some other coexisting autoimmune disease with pernicious anemia. But the most important point, and I'm sure a lot of you have already heard of that, is the presence of some certain antibody against the parietal cell of the stomach, and also antibody against the intrinsic factor. Okay, so we have to explain that thing. And after we have explained these two factors, then I will discuss this flowchart. This is an overall flowchart about the development of pernicious anemia. Okay, so going back to the autoimmune factors, like I said, there are two types of antibody produced in pernicious anemia. The first one is antibody against the parietal cell. Okay, antibodies are produced against certain antigens which are present in the surface of the parietal cell or inside the cytoplasm of the parietal cell. Okay, but that doesn't mean that if you find antibody against gastric parietal cell in someone's serum, that person has pernicious anemia. Okay, so remember, 85% cases, in 85% cases of pernicious anemia, there will be antibody against parietal cell present. However, patient who has chronic atrophic gastritis but doesn't have pernicious anemia, they also have about 30% to 60% antibody against the gastric parietal cell. And even relative of patient who has pernicious anemia, they can also have 35% antibody against parietal cell in their serum. And also remember, normally in certain females after the age of 70 years, it is normal to find antibody against parietal cell. So the point I'm trying to make here is, in pernicious anemia, we will see antibody produced against the gastric parietal cell, but however, presence of gastric parietal cell, presence of antibody against gastric parietal cell doesn't give us confirmed diagnosis that the patient has pernicious anemia, because some other disease condition may also have that amount, but that is in a lower quantity. Okay, so now that we have discussed the two factors, the genetic factor and the autoimmune factor of pernicious anemia, now I will show you a flowchart, and here we will discuss what is actually happening. So like I said, initially we are having antibody produced against the parietal cell of the stomach. Okay, so parietal cell antibody is produced, and that antibody is doing what? It's causing shrinkage of the parietal cell. And recall, what is the function of parietal cell? The function of parietal cell is not only to produce intrinsic factor, which is required for vitamin B12 absorption, but also to produce hydrochloric acid. Okay, so these patients will have decreased amount of hydrochloric acid, and that is a term known as achlorhydria. Okay, so antibody produced against the gastric parietal cell, that will cause gastric atrophy. One thing you have to know, this atrophy will occur throughout the body of the stomach. You know, recall, a stomach has different parts. It has a fundus, a body, antrum. But the thing is, this gastric atrophy will be not found in the antrum of the stomach. So as there is reduction in the size of those gastric parietal cell, there will be decreased production of intrinsic factor. Moreover, there will be also antibody produced against the intrinsic factor themselves. So not only we are having reduced production of the intrinsic factor, now we are having antibody produced against the intrinsic factor. And so as a result of those antibody against the parietal cell and antibody against the intrinsic factor, there will be even more reduced amount of intrinsic factor, and that will result in vitamin B12 deficiency. Okay, so once there is reduced vitamin B12 absorption, that will result in mainly four things. One is macrocytic anemia. There will be problem in the tongue, inflammation of the tongue, which is known as glossitis, and some nerve involvement, mainly peripheral neuropathy, and subacute combined degeneration of the spinal cord. Now, you may be asking why. The reason is vitamin B12 is vital for DNA synthesis. Remember, tetrahydrofolate and vitamin B12 are important for pyrimidine synthesis. Okay, so if there is less vitamin B12, then what will happen? DNA synthesis will be reduced. And always remember, the blood cells are formed in the bone marrow, and in the bone marrow, the more mature the cells get, they reduce in their size. Say for example, if this was the pluripotent hematopoietic stem cell, which is the origin of all blood cells, you know, and say that thing is dividing into more and more mature cells, say for example pro-normoblast or pro-erythroblast, then early erythroblast, intermediate erythroblast, late erythroblast, then reticulocyte RBC. So as those cells are maturing, they are dividing and they are reducing in their size. So when we're having vitamin B12 deficiency, that is causing lack of DNA synthesis, that is hampering this cell division, and sometimes cell division is getting stopped 1 or 2 stages before the complete maturation is achieved. Okay, so as the cell division is stopping, so look at the size of this cell compared to this cell. This one is larger, right? So they are resulting in formation of large cells in the bone marrow, which are known as megaloblast, and the RBC which are formed from those precursor cells from those megaloblasts are known as macrocyte. And remember, we say RBC in the peripheral blood is macrocytic when MCV, that is the mean corpuscular volume is more than 100 femtoliter. Okay? So that explains why we're having macrocytic anemia, large RBC, when we're having vitamin B12 deficiency due to pernicious anemia. The answer is due to impaired DNA synthesis, due to formation of immature cells, okay, which are larger than the mature cells. Inflammation of the tongue, actually the mechanism is also same here. In our tongue we have some cells which divide very rapidly, but since we're having DNA synthesis problem, so they can't divide rapidly, and so they are having some inflammatory problem in the tongue. Now these two things are important. Why will we have neurological problem and subacute combined degeneration in pernicious anemia? To understand that, we have to go to biochemistry. Remember, vitamin B12 is a very important vitamin, not only for producing pyrimidine or not only for producing DNA, but also it is important for adding a methyl group to the compound homocysteine and forming methionine. Okay, so the reaction is like this: homocysteine that is binding with methyl group, which is given to homocysteine by vitamin B12, and then homocysteine is converted to methionine. So that reaction needs vitamin B12. Now when we're having vitamin B12 deficiency, homocysteine will not be converted to methionine and homocysteine will accumulate. And remember, when one substrate of a reaction cannot proceed to a certain pathway, it goes to another pathway, so that homocysteine will go into another biochemical reaction and it will form something called methylmalonic acid, and that is very harmful for the nerves, and that will result in peripheral neuropathy. So the homocysteine will make something that is harmful for the nerve, and that will result in peripheral neuropathy and also subacute combined degeneration of the spinal cord. Remember, what do you mean by combined degeneration? In the spinal cord we have both motor and sensory pathway. When both motor and sensory pathways are having degeneration, then that is known as subacute combined degeneration. So as you can see, when I was talking about the entire flowchart, I just also mentioned the main clinical features. So now let's review those clinical features. What were the clinical features that we will see in a patient of pernicious anemia? Okay, so the first one is definitely anemia. Usually anemia is occurring slowly, and sometimes it may be absent. The anemia may be absent, and the diagnosis may be done in some other routine examination. Okay, the patient came for some other routine examination, and then the MCV was found larger than 100, and then you started to suspect something is wrong. Okay, but remember, age is very important. If a patient comes to you whose age is below 30, you have to exclude the other causes of macrocytic anemia before suspecting pernicious anemia. Okay, the patient may be simply strictly vegan. Yeah, you know, strictly vegans, they don't take animal foods, you know, foods from the animal source, and vitamin B12 is rich in animal source. So it may be simply a dietary habit. Okay, so pernicious anemia is very rare before the age of 30. That's the first clinical feature, anemia. The second clinical feature we have already discussed, glossitis. Now patient won't come to you and say, "Doctor, I have glossitis." What will be his or her complaint? One thing the patient may say that they are having pain in the tongue, pain sometimes maybe in the whole mouth, and the tongue will be red. The tongue will be red and shiny because there will be loss of those papilla of the tongue. Okay, so those are the clinical features of glossitis. The patient will have some abnormal sensation that will be due to peripheral neuropathy and subacute combined degeneration of the spinal cord. Okay, so these are the main clinical features of pernicious anemia. The next point that we have to discuss is the lab diagnosis. How can we diagnose pernicious anemia? Okay, so we will, once we are suspecting pernicious anemia, we will try to measure the serum vitamin B12 level, and also we will look for some antibodies against the parietal cell and against the intrinsic factor. And remember, there is an important test for your exam, which is the Schilling Test. So I will now explain what is the Schilling Test. It is a test done to understand if the patient has some problem in vitamin B12 absorption or not. How do we do Schilling Test? Okay, the way we do Schilling Test is, first we will ask the patient to fast. After fasting, the patient will come and then we will give him 1 microgram oral vitamin B12, and then we have to wait 2 hours. After 2 hours, okay, remember the 1 microgram oral vitamin B12 is radioactively tagged. Okay, so radioactive vitamin B12, we are giving 1 microgram oral, and then we will wait for 2 hours. After 2 hours, we will give the patient 1000 microgram non-radioactive, this one is not radioactive, 1000 microgram vitamin B12 parenterally. Okay, and then we will measure the amount of vitamin B12 in that patient's urine for 24 hours. Now, if the result is about 10% of the vitamin B12 given, that is normal. Okay, that patient has normal absorption of vitamin B12. But if the result is less than 10%, then what will we do? We will again give the patient another 1000 microgram vitamin B12, and then we will again give the patient the radioactive vitamin B12, but this time we will also add intrinsic factor with that radioactive vitamin B12, and then we will measure again in the urine the amount of radioactive vitamin B12. Now, after doing all those extra things, giving 1000 microgram second dose radioactive vitamin B12 with intrinsic factor second dose, after doing all those things, if now the result again goes up to 10%, then we can say we have confirmed pernicious anemia. Okay, so that is all about Schilling Test. Now, also in your exam you may have some questions from the findings of pernicious anemia in the peripheral blood and bone marrow. So I will briefly discuss those things now. What will we see in the blood picture of a patient with pernicious anemia? Well, since it is anemia, so hemoglobin level will be low. Regarding the red cell indices, I have already mentioned the mean corpuscular volume, MCV, will be more than 100 femtoliters. The cells will be oval macrocyte. Okay, so what will we see regarding RBC? There will be oval macrocyte. One important finding in the peripheral blood of pernicious anemia patient is the presence of hypersegmented neutrophil. Now, normally neutrophils, they have 3 to 5 lobes. Okay, but in case of pernicious anemia, they may have more than 5 lobes. Then that will be known as hypersegmented neutrophil. But sometimes we can also say a peripheral blood film contains hypersegmented neutrophil if neutrophil which have 5 lobes, their percentage becomes more than 5%. Okay, neutrophil 3 to 5 lobe is normal, but normally neutrophil, those neutrophil that contain 5 lobes, their percentage is less than 5%. But whenever their percentage of 5 lobe containing neutrophil becomes more than 5%, that will be also known as hypersegmented neutrophil. Okay, regarding the bone marrow finding, what will we see in the bone marrow? The main thing we have already mentioned, that is the presence of megaloblast. What is a megaloblast? Megaloblast is an unusually enlarged erythroblast that is happening here due to vitamin B12 deficiency. Recall, megaloblast can also occur due to folate deficiency, but that is another topic. I have a separate lecture regarding megaloblastic anemia. You can view that if you want to know more about megaloblastic anemia. So coming back here in pernicious anemia, so these were the main lab diagnosis of pernicious anemia. So one thing you may also want to add, in the bone marrow there may be presence of some giant stab cell. Okay, giant stab cell. Now, what will be the treatment of pernicious anemia? So now we are understanding that pernicious anemia occurring due to some difficulty in absorption of vitamin B12. So the treatment is simple. We will just bypass that absorption pathway and give vitamin B12 directly. And the way we do that is we give injection of vitamin B12 either intramuscularly or deep subcutaneously. Okay, and what is the dose? We begin with 1000 microgram intramuscular dose given daily for 1 week. That is the initial dose or the loading dose, and then we will give 1000 microgram at 1 month or 4 weeks interval, and after that we will give 1000 microgram at 3 months interval for life. Okay, so that is our treatment plan for pernicious anemia. And if the neurological manifestation did not develop, if the diagnosis was early, then the prognosis of pernicious anemia is very good. The patient may live a completely normal life, just have to take vitamin B12 regularly to maintain the level of vitamin B12. Okay, so this is in short about pernicious anemia. If you want to know more about the main group in which the pernicious anemia is, which is the megaloblastic anemia, do check out my other video. Okay, so before finishing this video, I would also like to add some advanced points that you may be asked in the exam, and that is regarding this intrinsic factor antibody. Remember, there are two types of antibody produced against the intrinsic factor. One is known as the blocking antibody and the other one is known as the binding antibody. Okay, so what is the role of blocking antibody? The blocking antibody blocks the formation of vitamin B12 and intrinsic factor complex. Recall that vitamin B12 cannot be absorbed unless that is bound to intrinsic factor, and that thing is blocked by the blocking antibody, and the binding antibody prevents the binding of that complex with the receptors in the ileum. Recall that ileum has receptors for intrinsic factor, and those things are blocked by the binding type of antibody against intrinsic factor. So that is an important point for your exam. Okay, so that's all for today. Hope it is helpful. Take care. Thank you.